There's a saying, I think it comes from Islam, die before you die so that when you die, you will not die. And that in order to have the best death possible, it's really it's a series of letting goes, of losses, and being okay with that and not holding on to things.
Walking alongside someone with serious illness takes compassion, skill, and a willingness to learn. Dr. Kevin Dieter is teaching medical students how to be with the dying. Hi, I'm Helen Bauer, and this is the Heart of Hospice podcast. The Heart of Hospice podcast is your source for compassionate and informative discussions about hospice and end-of-life care. I'm a certified hospice and palliative care nurse with over 15 years of experience. Whether you're a caregiver, someone with a serious illness, or you simply need to know more about hospice care, this podcast is for you. Join me as we explore all the aspects of hospice, from the details of caregiving to the emotional and spiritual dimensions of end-of-life journeys. For more resources and to connect with me, visit theheartofhospice.com and find us on Facebook, Instagram, and LinkedIn. Keep listening for today's episode.
This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
This episode is being sponsored by Halo Care. Whether you're supporting an aging parent or planning for your own independence, Halo Care empowers you to live confidently at home. From personal care and home safety to meaningful social connection, Halo Care gives you peace of mind knowing someone's always there. Learn more at halocaregroup.com/USA or check the show notes for the link. Halo Care, where technology meets compassion and home feels like home.
Dr. Kevin Dieter is currently a clinical associate professor at family medicine at Northeastern Ohio Medical University. After having a 35-year career as a hospice and palliative care physician, he retired from full-time clinical practice, but he continues to work and teach part-time while working as an associate medical director. He is board certified in both family medicine and hospice and palliative medicine, and he's a fellow of the Hospice and Palliative Medicine Academy. Kevin helped to develop the nationally recognized palliative care curriculum, which features the concept of a hospice patient as a teacher. He recently created an asynchronous virtual learning module called Being with Dying that allows every medical and pharmacy student to understand the skills and attitudes needed to be at the bedside of a dying patient. His ongoing hope is to incorporate that wisdom into medical education throughout the medical and nursing education system. Early in his career, Dr. Dieter faced an ethical dilemma when a patient asked him to help her die. Without any experience in end-of-life care, he learned how to serve patients who were dying, and he calls this patient his best teacher. He attributes her, Mary, he calls her, to changing the trajectory of his career. When Kevin was in medical school, there was very little training on end-of-life care, and as a doctor, you didn't want to be part of the death of a patient. Death was seen as the enemy, as a failure. He says his greatest strength is being able to lay down his medical bias when he enters a dying person's space. His idea of a good death has also changed through the years, and Kevin offers us his current perspective on that particular phrase. There are 3 pillars to his view of end-of-life care, and he shares those with us. You can find Kevin's work and connect with him at walking-home.com. Kevin, welcome to the Heart of Hospice podcast. It's great to have you with me.
Thank you. Really great to be invited.
I was so excited to get connected with you on LinkedIn when I saw the work that you're doing, because it's pretty unusual for a physician to be feeding end-of-life and death care education into medical schools. And so I'm thrilled to be able to feature what you're doing on the show. So we are going to start with an icebreaker question that I chose out of the Dementia Deck. It's part of the family of conversation starter decks created by Lisa Paul, who's a hospice social worker. The death deck is one, the end-of-life deck, and now she's got the dementia deck. And it's a great way to reflect on end-of-life wishes and end-of-life conversations. So this is what I chose for your question.
Okay.
If I'm unable to safely swallow food or drink, A, give me a feeding tube. I want to live as long as possible. B, that's my body's way of letting go. Listen to it. Or C, it depends on how I'm doing otherwise.
B.
B. Yeah, working in end-of-life care, there would have been a wrong answer for this. It's still your personal opinion, but yeah. So tell me why you wouldn't do a feeding tube.
Yeah, I mean, there's so many caveats to that question, as I think answer C alluded to a little bit, but in general, if it's something acute and I'm otherwise relatively well, and I need a temporary feeding tube to allow my esophagus to heal or whatever, I would rethink that. But if I have a life-limiting illness, I don't see any point in prolonging it. And also, there's so much data out there about feeding tubes and the problems they cause. We used to think that they solved all these problems, but when you look at all of the data retrospectively, it increases the risk of aspiration pneumonia and infections, and your life isn't prolonged and you have more suffering. So for all of those reasons, I would say no.
I think that's a good question to have a conversation about, because that's a really sticky point for a lot of families. Mom has advancing dementia and now she can't swallow. So the knee-jerk reaction is, well, we can't starve her to death. We've got to feed her. So feeding tube is the way to go.
That's absolutely right. Yeah, it is. Yeah. Those are the hydration and nutrition at the end of life. Those aren't cognitive decisions for families. Those are emotional decisions. And exactly as you pointed out, we can't let mom starve to death, or we can't let mom dehydrate. We have to do something. And so my experience, just very quickly in doing that, is that we understand where they're coming from and we support that. And you need to validate how hard of a situation that is for them and why they're feeling the way that they're feeling. But I think it's, we need to do our diligence medically, particularly with palliative and hospice care, and tell them what the facts are and tell them all the data and what we know about end-of-life hydration, nutrition. And then just give them time and space to work with that. It's usually not one conversation. It's usually a series of conversations. And, sometimes, particularly with the hydration issue, you may need to prove it to them. You might offer a time-limited trial of IV fluids for a day or two, and then reconvene and say, let's see, how mom's doing now after we talk. So, yeah, that's a really tough place. And again, one place that I think we need to teach, young doctors, whether they're medical students or interns or residents, even fellows. That's one way that we can shepherd families through the illness of their loved one. And that's kind of the metaphor that I like to use.
Yeah, those are very emotionally charged conversations, because eating and drinking is a sign of life. It's a sign of thriving. It's very natural. It's unnatural to have a person that doesn't eat or drink. And that the inevitable conclusion is the end of the life. And I think, in my experience, if you have several family members, several kids that are weighing in, a lot of times it's very hard to get agreement on that.
Exactly. And that's, again, part of the struggle with all of this and part of the challenge. And one of the reasons why, we need palliative care folks and hospice folks that are willing to be with families through that. One of the catchphrases that we always use to remind families about the nutrition and the hydration to that, for that matter, is that your loved one is not eating or drinking because they are dying. It's not that they are dying because they are not eating or drinking. And it's those kind of things that we just need to repeatedly shift their focus a little bit. But again,
Yeah.
everybody's going to come to that point, eh, at their own pace in the family. And it can be really hard sometimes. And sometimes, family members don't get there.
Yeah.
Once again, when we look at big picture, it's another reason for advanced directives for somebody to be deemed to be the power of attorney to make those decisions, and for the rest of the family members to kind of understand where that's coming from.
My mom made me her medical power of attorney, I don't know, 15 years ago, 13 years ago. And I specifically asked her that question. And she ended up having dementia, of course, right? I had no idea that was coming. So I was so glad that we had that conversation, because I was able to tell my siblings, as my mom's MPOA, she told me specifically, no tube.
Yeah.
Because that was the first question. How do we feed her? We don't.
Yeah, boy.
Yeah.
You bet. Because if a lot of people, they say, well, I did the advanced directive, check that box. And I said yes to mom, who wanted me to be her power of attorney for healthcare. But you don't have a conversation about anything. And so then in your situation, you were able to say, mom told me, instead of, I don't think
Yes.
mom would want that. And so the power that carries, and it takes such a weight off of the POA's shoulders when they've had those conversations, instead of assuming that they think they know what their loved one wanted.
Yeah.
Yeah.
I wasn't actually making a decision. I was only following a direction.
Right. Yeah, good
Right.
point.
Which would have made my mother really happy, because I don't think I did that when I was younger. So let's focus on your work.
Yeah.
You have a unique positioning where you're working now, with the education you're providing for medical school, the programming that you've written. And I want to know how you got into this. You had a very special patient. You tell her story. She asked you to help her die.
Yeah.
Tell me that story.
Yeah. So I was trained in family medicine. That was my residency. And when I started my practice, I was a solo practitioner in a smaller community outside of Canton, Ohio. And within the first month, I had a new patient come in, accompanied by her niece, who was her only living relative. I call this patient Mary, and I also have deemed her my most profound teacher. So Mary was 93 years old. She had CHF, COPD, osteoarthritis, hypothyroidism, and was on a variety of meds to keep her asymptomatic, although she wasn't very functional at home. And she came into the office the first time and said, Dr. Dieter, I'm here for one reason. And, I'm this brand spanking new family doc out of training, ready to handle just about anything, and not knowing what I didn't know. And she said, I'm ready to die and I need you to help me. And so honestly, Helen, I didn't know what to do with that question, because I was not trained for that scenario. This was 1988, 89. So my instinct was to do these reflexive things like screening for anxiety, screening for depression, all of these little tools that I had. But that didn't really answer the question for me about how I responded. And she helped me. She said, look, I realize this is probably hard, but if you don't help me with this, then what I will do is I will someday at home, I'll just stop taking all my medications, and I'll just die at home.
Oh, wow. Without any support or help.
Yeah, without any support, because this was before we had any hospice programs in the area. So I couldn't even punt there. So, make a very, very long story short, I, consulted with everybody that I could that I knew that might have some insight, had several visits with Mary and her niece in the office. And then finally, we came to the joint decision that I would admit her to the hospital where I had privileges and I would just withdraw all of her life supporting medications. And that's what we did. And over the next 12 days before she died in the hospital, that's where I call Mary my most profound teacher. So I had to learn how to use basic medications like morphine and Ativan and those kind of meds to mitigate symptoms. I really hadn't used that before, but she taught me so much more than that. She really taught me about how to be with someone at the end of life. And she taught me how folks can face their own death with dignity and grace. That when I entered her room at the hospital, and I rounded every morning, I was entering sacred space. And she also, I think one of the most profound lessons that I've learned over and over again is to realize that I could not fix all of her suffering. That sometimes the best I could do, and it is the best I could do, is to just pull up a chair and sit next to the bed and just be there for her and with her in her suffering. And that was a huge step for me to make because that's not how I was trained.
Yeah, it's a total about face for the mission, do no harm, and you work to help people. And the whole idea is you fix it and you cure it and you send them on their way. She knew something you didn't, that she was ready, that there was peace and there could be comfort. And she was wanting to teach you that. I got to ask you, what was the team's response, the people who were working on the floor at the hospital? Because nurses don't get any training like that either. And back in the 80s, obviously, we weren't getting, the hospice benefit was only a few years old back then. Mm-hmm. What kind of support, what kind of response did they have to having her there?
Yeah, so that's a great question. That was an unusual situation. And back then, it is so hard to get admitted to the hospital now. You have
Yeah.
to meet such acuity levels. You could never. It was a different situation back then. So first of all, I was able to admit her and keep her there for 12 days, watching her from a medical standpoint. I'm surprised they let me do it, but they did. But the nursing staff and the other staff were actually amazing. I think they were learning too, and I think they probably felt kind of, I don't know, I'm not coming up with the word better, but about all of this because they realized that I was struggling too. And I didn't come in like I had all the answers and they were supposed to follow my instructions and directions. We were doing this together. And so I think that made it a lot easier for her and for them. I don't remember one person that had any pushback. And afterwards, you would think that if there was an employee that struggled with it, you'd hear about that through administration, that they would go and say something. And none of that happened. As a matter of fact, it wasn't long after that the hospital system decided to start their own hospice program, and they reached out to me to be the medical director. They said, "Hey, you've done some of this kind of thing," and I didn't know anything about hospice. So that was the door that was opened for me by Mary, that allowed me, number one, to understand this, but then to go down the path of hospice, then palliative care, and then everything that's happened since that time.
Yeah, she changed the trajectory of your career completely.
She did. And it is kind of a sidelight when I talk to medical students who are trying to figure out what specialty they want to focus on. I'm a very strong proponent for family medicine because I tell them that family medicine by itself is a wonderful specialty, but it also can be a launching pad. That there may be a door open for you that you don't see coming, and that takes you down a parallel course, whether it's sports medicine or it's women's health or addiction medicine. There's all of these places where you can specialize within the specialty of family medicine, and it's a great sounding board. So that's what happened to me.
What unit was she on in the hospital?
Just a general medical floor.
Yeah, that is unheard of. You have to be in ICU on death's doorstep these days to spend 12 days in the
Yeah.
hospital.
Yeah.
Yeah,
Yeah.
that just doesn't happen.
Everything lined up.
Yeah, that certainly wouldn't happen today.
Mm.
So the current focus of your work is you're teaching doctors, medical students,
Mhm.
about death and dying, how to care for these people and how to be present for them. Why are doctors, nurses have asked this for a very long time, why are doctors so unprepared to provide support for somebody who's dying?
Yeah. Well, let me start by saying it's better than it was. Um, Things are
I
improving.
agree.
But so I'll go back to when I trained, graduating from medical school in 1985, death was the enemy. That was the teaching. And
Right.
we, the training was so different. We didn't talk about death and dying in medical school. We didn't have humanities courses that focused on it. That was in the time when you were a resident, you worked those horrendous hours, and all of that to beat it into you, to beat you into being a physician, because that's the way that it was always done, and just kind of suck it up and
Right.
do it. And there was no room for any of this, uh, any these other things besides, death is the enemy, we need to save the patient. And so that was reinforced to us, Helen, when we would have M&M rounds, morbidity and mortality, where you would, as a group, let's say you were doing an internal medicine rotation in the hospital and one of the patients died, then we would get together as a group and dissect that death. And it wasn't a pleasant thing. I mean, it was meant to teach us, and it did. That was a great way to learn, but the focus wasn't, um, what did you do to allow them to have the best death possible? It was, what were the mistakes that were made? And it was kind of a uncomfortable, brutal way to look at death, and like a reinforcement that you don't want to be any part of a patient that dies. So that
Right.
was certainly part of it. And then the experience that we had with death back then was either a failed CPR event or, withdrawal of life support in an ICU setting. And back then, we weren't part of that. It was like, okay, take them off the vent, give them some morphine, on to the next patient. Um, and so that was kind of the setting that I grew up in, and it just made it hard. Then, thank goodness, hospice and palliative care were kind of born after that. And there started to be a big focus. There were a lot of other dots that were connected in this change for a better way to understand how to be a physician in caring for those that are critically ill and dying and have chronic serious illness beyond just hospice and palliative care. But that was a big part of it.
Yeah, definitely. It's a little horrifying when you think about it now. But death was the enemy. Death still is the enemy. Nobody in a hospital wants a death on their statistics, right? They would
Right.
prefer not to. And that's why they have M&M reviews,
Correct.
right? Where could we have done a better job so this wouldn't have happened?
Right.
So it's an interesting reframing of the question, how can we do a better job so this can happen? So the death can happen, and it's a good, allowing a natural death.
And, it would be wonderful. And I'm sure this happens somewhere where when someone does die in a house in the hospital and they had a good, what they would call a good death. I've got my own opinions on that term, but maybe
Sure.
to dissect that so people learn in a positive way. Here are the things that you all did as a team to allow, Mr. Dieter to have the kind of death he wanted. Um, it probably takes one or two of those to get the idea.
But we don't do that. We have debriefings for occurrences and events,
Hmm.
but only usually for terrible things that have gone wrong or where mistakes were made. But we don't sit back and say, hey, this was a textbook case of getting everything right. What were we doing that made it so good?
Yeah.
I like that idea.
Yeah. And even in the ways that we have to process our feelings about bad deaths in people that died. There's that system called the Schwartz rounds, where a group of people that were clinicians, care providers, colleagues that were involved in the care of someone who died, and it was traumatic in some way, get together in a big setting, often an auditorium, and the folks involved in the care are on a panel and they just share their feelings. Everybody else in the auditorium learns from it. But I can't remember going to a Schwartz rounds where it was what we just talked about, where it was a good outcome. And let's talk about how that made me feel that this person had the kind of death they wanted.
Yeah. What did we get right along the
Yeah.
way?
Yep.
It's an interesting mindset, and just approaching it from a different perspective. I think in a much more positive way. After you hear from our sponsor, Dr. Dieter is going to share his 3 pillars of end-of-life care.
This episode is being sponsored by Halo Care. Caring for a loved one at home can be both rewarding and overwhelming. At Halo Care, we're here to help you find the balance, combining technology and heartfelt support so aging at home feels safer, easier, and more connected. Our 24/7 Care Hub team is always just a call away, keeping families informed and seniors supported around the clock. From personal care and home safety to meaningful social connection, Halo Care gives you peace of mind knowing someone's always there. Whether you're supporting an aging parent or planning for your own independence, Halo Care empowers you to live confidently at home, surrounded by care that's compassionate, human, and truly personalized. Learn more at halocaregroup.com/USA or check the show notes for the link. Halo Care, where technology meets compassion and home feels like home.
So you describe us, the healthcare here in the United States, as being in a season of unlearning. I absolutely love that term because I use that term. I think it's fantastic. We are relearning how to help people die.
Mm-hmm.
How did we get to having such a medicalized, sterilized, hospitalized death here in the U.S. to begin with?
Well, there was a lot of factors in that. And I always caveat this at the beginning by saying medical intervention during illness and during the dying process, it's not a bad thing. It's not that we don't need that. It certainly is very beneficial, but we just need to know how to titrate it. But what happened is, let's say 100 years ago in this country, most people died at home. And so children in that household knew what death looked and smelled and sounded like. So they grew up realizing that death is part of life. Grandma died in the parlor. My brother died in the parlor. And it was a community that came together to support that family. And there were physicians back then that understood what the role of a physician was. The prime example is Sir William Osler. We know him and we call him the father of modern medicine because he taught us so much about physical diagnosis. But if you actually study Sir William Osler, he published articles in medical journals about paying attention to the spirit and the soul of the patient and understanding that there was more going on when that person died than anything that the physician could tend to. There are photographs of him just sitting at the bedside of a dying person. In his role as a physician, and he wrote and he taught about it. So that's kind of the way it was. But then it seems after World War II was, I think many people would say, the linchpin. After World War II, there was a rise in medical technology. There was a rise in this need for patient autonomy and also consumerism. And so our culture said, I don't know if we want to keep caring for our folks, our loved ones at home when they're dying. We have all this medical technology and all of these other things. Let's turn this over to the healthcare system and let's kind of let our loved ones die in the hospital. Let the doctors take care of it. Well, the problem with that was the doctors weren't ready to take care of that, number one. And number two, by doing that, it sterilized the dying process. It made it a medical event, and it stripped it of all of its cultural and social and spiritual, all of these um, significant aspects of dying that had been part of how people had died for eons before that. Now it was, what's the diagnosis? What are the medications to keep them comfortable? And that was the focus. And move on to the next patient. There was a study done in the mid 1990s called the support study, where they looked at, I forget how many thousands of patients across the country, 6,000 patients, I think, maybe in six different large medical centers. And what they realized, Helen, is that we did a lousy job, even in the 1990s, of caring for people at the end of life. More than half of them were in significant pain the last 3 days of their life. Most of the time, the physicians didn't ask about advance directives or even pay attention to them if they knew that they were there. The families left feeling like the doctors never talked to them. They had complicated grief. We just didn't do a good job. And once again, it's better now. It's better for a lot of different reasons, but that was kind of the big shift.
Well, we relied on doctors who had received no training
Yeah.
to do that job. We rely on nurses who had received no training to do that job, to be able to talk, to have the skills. So tell me the skills that you try to employ when you're at the bedside of someone who's going through the dying process. What would you say your greatest clinical strength is as a hospice doc?
Um, I would say that it's starting by leaving my agenda at the doorway of the patient's room. There is, I think, I mean, I could talk for hours about this, but if I whittle it down to a few things, it's realizing um, that there's so much happening to a person when they're dying that's not medical. It's nothing that can be measured. It's not scientific. And so when I enter the space of someone at the end of life, I need to be open and aware of that I'm not in control of what's happening. The patient's actually in control. And what I need to do is I need to protect that space from all of the medical things that might try to sneak in there and intervene and allow that person to have the kind of death that they want. There's always a lot of talk, and I've taught for years about good and bad deaths. I've gotten away from that. And my term now is the best death possible. I think good and bad deaths are pejorative, and there's an assumption that we can guarantee this good death, but not everybody's idea of a good death is the same. So I don't know exactly all the time what the best death possible will be for each patient that I take care of, but I know that I need to do do what I can to find out and allow that to happen the best that I can. There's so many other caveats that we could add to that, but I guess secondly, and I think we'll talk about this at some point, but the three pillars that I've learned after 36 years that I teach upon is that the dying are teachers, that we are the medicine. We, as human beings, perfectly imperfect Kevin Dieter at the bedside, can be at times the most powerful medicine that I bring to the bedside of a patient. And then lastly, much of dying is a spiritual process. There's a medical component, the physical body's dying, but really what's driving everything is this non-physical part of every human being. So I need to be kind of aware of that and pay attention to that. And sometimes just as I did, as Mary showed me, invited me to sit down and just show up, that presence can be sometimes exactly what's needed, and to model that for other people, because that's not an instinct that medical folks have. At least physicians don't have that. There's a concept also. This gets a little bit into the woo-woo part, which I think you have to be okay with when you're doing this work. But there was a Lakota shaman in the Lakota tribe by the name of Fool's Crow, who described that when he was sitting with someone in his tribe who was suffering, whether it was something while they're, living their normal life or at the end of life, that he imagined himself to be a hollow bone. And by that, he meant that he was just a vessel, and that whatever was supposed to happen, if anything, from the Great Spirit would come through him and into the situation or into the person in front of him. I challenge physicians to become hollow bones. There are times when, again, leave our agenda at the door. Just show up. And honestly, Helen, there have been times that I have said things to patients when they're dying. I have no idea where it came from. It wasn't like I thought it, like I had my script before I went into the room. And it's not like I'm speaking in tongues or anything. It's just I happen to say or give an insight or a metaphor or something that seemed to be exactly what they needed to hear or the family needed to hear. And so there's always that I have to trust. But then again, I've gathered all of these ways at looking at death and dying. Some of it's metaphor, some of it's Buddhist teaching that really help patients and their loved ones understand all of the things that don't make sense when we're dying, the ups and downs of the clinical condition, the visioning, the symbolic language, the terminal restlessness. It, if you've not been next to someone that you love that's exhibiting those things, it's crazy because you're already in this space that you don't know how long it's going to be, and you're in grief, and you've got your own life to get back to, all of these things. And so again, I've found ways to talk to folks that seems to use that term again, shepherd them through this little bit. So I guess I'll leave it at that for now.
Well, you call it woo-woo, but what I hear you saying is there's nothing that you need to pull from an A&P textbook. That's not what people need. I always use the term, we're not driving the bus.
Right.
We're along for the ride.
Right.
Yeah.
Yep.
But I do think when you acknowledge the spiritual side, the emotional side, the psychosocial side of a death, because you're talking about not just the person, but their family, their caregivers, there's a validation, and it reaches a different place inside their grief. And I'm with you. It drives things. And if you ignore it, I don't know, maybe that's how we express our own agendas. Because let's face it, we walk in the door with an agenda to begin with. The first thing is I have to get my assessment documentation taken in so that I can complete my note.
Right.
Right? I need to get to my next patient, and I only have 45 minutes to give you, so that's the second thing on my agenda. And so maybe I don't have all that much time to listen to you. There are so many things we do that are about us as providers, and it is about our agenda. And then, of course, we take our own biases in there with us as well, explicit and implicit as well.
Yeah, really, really good point, Helen, particularly about the biases. We, to say that we don't have them, we do. And so the number one, stop lying to yourself. You've got your own biases. And so we need to be, you need to face them and understand it and kind of keep them in their place and do your work despite that. Again, this all speaks to the clinical part, the medicalization of death and dying. And even for hospice and palliative care folks, we have the hoops that we have to jump through. We have to do our assessments. We have to document it. We have to complete all of these tools that now we have to, and then we've got the next patient waiting for us, which, Dame Cecily Saunders, when she created the modern hospice model, she took her wisdom from the Middle Ages, from the Ars Moriendi primarily, and it wasn't medical. It was all of the other aspects of total pain, the physical or the psychological, the emotional, the spiritual, all of those aspects of pain is what we need to pay attention to. And she used that to create the hospice model of care, a team of professionals to deal with that would help each other and take care of the patient and their loved ones. Perfect model. And sprinkle it with, a little bit of the medical stuff now and then. And her one of her famous quotes was, instead of saying, "When was your last bowel movement?" when she would walk in to see a patient, she'd say, "How are you within today?" Imagine that, a doctor saying, "Are you at peace with what's going on?" But she warned us that when the hospice model came to the United States, that this is what's going to happen. You will medicalize it. And that was her worry, and it happened. And so now we've medicalized it, and we lose sight of what's been happening for centuries about all of those aspects because we have to get our work done. So that is the challenge. And as a very small aside, I'm on this push now to recognize the importance of end-of-life doulas and end-of-life care and find innovative and creative ways to incorporate doulas into end-of-life care. And it seems like a no-brainer to me that doulas bring that skill set to the bedside. Everything that we left behind, the doulas are sitting there waving their hands saying, we do that. So when the clinical folks are too busy doing all the medical stuff, then the doulas can come in and help us and model for us and fill in for us what the patients and families might need.
Yeah, that's pretty amazing. Kevin, to summarize the 3 pillars, tell me the 3 again so listeners hear very clearly.
Sure. Pillar number 1 is the dying are our teachers. So every dying person I've cared for over 36 years has taught me something. It didn't stop with Mary. Mary just said, you got to pay attention. And so it could be what they tell me or what they tell us about how to live a life or what their experiences were or some advice. It could be that they tell us things that they appreciated in their healthcare providers and things that they didn't appreciate. But oftentimes it's the collateral lessons that this person made these choices and this is where they are, or this is how they manage this issue in their family. So we always can take away stuff from the people at the end of life. Whether they know it or not, they're going to be teaching us. Secondly, that we are the medicine. That of course with my training and all of that stuff, I've got all of these meds that I'm privileged and authorized to use to provide relief or mitigation of multiple physical symptoms, and I use those. But I think my biggest medicine is me showing up and not running away and being there, and all those things already talked about. And then third is simply that there is a medical component to dying. The physical body is shutting down. But really what's driving this in the third takeaway is that dying is primarily a spiritual process. And that speaks to all of the things that aren't medical that are happening, that at the end of the day is I think, to a certain extent, impacts how someone dies and how long it takes them to die.
I love this advice. Okay, we're going to dig deep. What is the most valuable lesson you've ever learned from your patients? If you have to only pick one.
Yeah. I think, and again, this is very ethereal, but if at that level, if we're talking about the most important one, is learn to let go. There's a saying, I think it comes from Islam, die before you die so that when you die, you will not die. And that in order to have the best death possible, it's really a series of letting goes, of losses, and being okay with that and not holding on to things. And that lesson, in the Middle Ages, there was a term called memento mori, remember death, where they reminded themselves every single day they were mortal. It wasn't morbid. It was a way to live that day really well, realizing they may not have tomorrow. So I think that's my memento mori, is simply that, is to practice letting go every day.
I love it. Kevin, how can listeners connect with you and see the work that you're doing?
So probably the simplest way is I do have a website. It's www.walking-home.com. Or if they don't remember that, just kind of Google my name and that'll probably pop up too. At the website, I outline some of what we talked about. I've got a blog there, and it highlights some of the things I've done about teaching medical students, which is about all of this, which has been really important to me. So, yeah.
That's great. This has been a fantastic conversation. Kevin, thank you so much for the work that you're doing to move us in the right direction and to change the way we work with the dying. Thank you.
Yeah. Thanks, Helen.
Thank Thanks for listening to the Heart of Hospice podcast. Check out our sponsor in the show notes and please leave a rating and review on Apple Podcasts. We would appreciate it if you would share this episode with your friends and family and anyone who needs to know more about hospice. Connect with us on Facebook, Instagram, and LinkedIn. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.